Okay. 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 Fine.
See, when you operate, there are three things that you can adjust to get a best focus. Number one is the patient, number two is microscope, and number three the surgeon. So we see a lot of beginners, they will be struggling to focus and they will not move the patient, they will not move the microscope, they will be struggling to focus. It is not that. There are three objects that you need to move: microscope, yourself, and the patient. All the three has to be moved for the best focus. Okay. So this is the fine focusing is this. This is the fine focusing. Yeah. So now this is the tympanic membrane, as you see here, is intact. So now the moment that is given to bone is given to you, check the site of the right side or left side, then wash the wound, the external canal thoroughly. So now number one tip that I want to give to the juniors when you do myringotomy, don't touch the bony ones with your suction like this or the external canal like this. This will cause bleeding, blood formation. The moment you touch the blood, again it will start bleeding. And instead of taking 3 minutes for myringotomy, you will take 1 hour time. Okay? Never try to touch the walls with the suction or instrument myringotomy. So now before we go to the myringotomy, first is use the left temporal bone. So now let us identify what is superior, what is inferior. So when I say superior in the temporal bone, that means it is always towards the superior like this, towards the occiput. This is the vertex. When I say inferior, it is towards the foot. When I say anterior, it is towards the face. When I say posterior, it is towards the occiput. When I say medial, it is towards the brain. When I say lateral, it is towards the exterior. Is all you have to imagine with one structure, with another structure, what is medial and what is lateral. So with that orientation, all of you see how a myringotomy is held. See this? This is the way you should hold, not like this. If you hold this instrument like this, which is such a long one, it will go and hit the surrounding structure. Now you see how I hold. I have every control on this instrument. So this will not touch the house. So when you operate, so both my hands are in the air. I cannot do this for a long time. Especially when I do stapes surgery or something, one hand of mine will be resting on the Mayo trolley, another will be resting on the surgeon's tool what I use. I will show you if the time permits and sir permits me to give you a lecture on drill systems, I think, where if you come up to here, your both hands should be rested for a fine work. So now I take this one and this is the I am throwing to a quadrant. I give the radial incision like this.
Yeah.
See, the incision for grommet is the radial incision, because if you give radial incision, what will happen is you are going to split the fibers, you are not cutting the fibers because the circumference is arranged. Whereas you want to do acute otitis media, what you will do, your idea is to drain the pus and you want to have a quick, so that you need to use circumference incision. So now I take the one lip of the grommet. See now this is the secret is take the grommet and keep on the incision site, and you take the best instrument is a curve. See, once you know driving, you can do whatever you want. But as a beginner, the best one is to use a 45-degree pick. See, with one finished.
Fantastic.
So you have to just at the waist of the grommet, you just have a one clip, it will go inside. So that is what you have to learn here. You are not going to learn surgery here, mind you. You are not going to become an instantaneous surgeon by doing one temporal bone dissection or seeing at one video in the YouTube.
Yeah.
You will be learning all the art of handling the instruments, art of moving the microscope, adjusting the interpupillary distance. But for if I am going too much into the basics, seniors who are sitting here may excuse me. I am keeping postgraduates and younger people in my mind I am talking.
Yeah. Yeah.
Okay? Please excuse me.
During dissection,
Yeah.
as many times you want to do. Okay, remove, put it again, remove, put it again, until you are totally satisfied about doing that particular
And-
procedure. And also, if you notice, he put the incision and insert the grommet exactly between the umbo and the canal wall.
Yeah.
Yeah, and it should neither touch the umbo nor the canal wall. If the grommet touches the canal wall, it will get extruded quickly because of the epithelial migration. If it touches the umbo, patient will have conductive loss because it will prevent the movement of the malleus. Remember this, huh? Yeah, so it should be exactly between umbo and the canal wall.
So now I take the canal incision for the
Yeah.
stapes. See now, most of the people who come here, I don't know what is the level of training, but please try to do this.
Center. Yeah.
Please try to do this exercise of stapes surgery, but please don't take too much of your time this technique because see whether we do stapedectomy in our practice or no, but you need to have the at least curating the bone. Cotton ball.
But JP, we are giving them sufficient time.
Okay.
Okay. Minimum 8 to 10 hours they'll get. If they want to do, they should do it. They should go ahead and do it. Take this.
My advice
If
is
you are lucky, if lucky tympanic membrane and stapes is there, please go ahead and do it. You'll all be given piston, all the equipment.
my request for the please, once you put the grommet, no, please remove that and give it to your assistant so that they can use because every consumables are very, very expensive. Let us not waste the resources. See now, see these are formally preserved skin. It will be so. It will not be like a supple in a live this one. See, I have come to the level of the tympan cannulus. So now, which is the best place for the hypotympanic? Into the there are two things. One is some people say that there is more space in the hypotympanum. You enter here, but for me, sickle neck, I have from the beginning somehow I see this is the posterior tympanic spine. This one, just there you open. Here, see there is a tympanic. Here I open and the cotton ball body.
Yeah, for beginners, still the posterior inferior region is still better, always safer because posterior superiorly we have incudostapedial joint, chorda tympani now, and also deeper facial now. So as a beginner, always practice posterior inferiorly, then gradually go up to the posterior superior region. Yeah.
So once you elevate this, you just keep there and maintain that with a cotton ball. Since okay, see this is the problem with a formalin preserved. So no problem. You just need to keep this flap away from you.
Yeah, if it is troubling you, you can
now
it out with that.
I want to see before I proceed for stapes procedure. I want to see three things. Can anyone tell what are the three things? Junior most. What are the three things that I want to make this as an interact question because one way communication is not good. So what are the three structures I need to see before I proceed to do stapes surgery? See, whenever I do stapes surgery, see the canal, if I see the 75% of the long process in that patient, I can do for less price also because I take very less time. The biggest trouble in operating for a stapes surgery is the exposure. Once the exposure is done, some patients will have too much overhang, where we need to remove too much of the bone. This specimen, you can see the long process of the incus 50%. So I am very safe. So that means I can finish my surgery very fast. See now, what I do, I release the and slowly see the delicacy of a otologist. Can be just you can say how it does surgery, but the way he clears the carotid now.
Yeah. See, is the direction of the instrument is using is going superior to inferior. So from important structure to away, not towards the important structures. That way, you don't disarticulate incudostapedial joint. You won't harm the facial nerve and contact tympani. Okay, and it's coming inside out. Yeah, remember the direction. Yeah.
And the instruments that needs to be replaced very often from your set is round knife, wash, sickle knife, and all the sharp instruments. See the house key what I am using. This is the Indian made ones. Take surgery. It is better to use one million for every case. It is worth also because it doesn't cost much, Then you can use those curate for the next surgery, other surgeries, tympanoplasty and all. But when you do stapler surgery, the so remove the bone. Number one. Number two is you take a untriangular handpiece and just keep this area with your diamond bell, then weaken that area and then you can remove if you are experienced enough. So now see this. Now the instrument what I am holding in my left hand is a suction. The suction tip is bigger than that what I want. That you need to recognize. When if you know which suction tip is at what point, that means you understood what is ear surgery. So now I take a smaller one and remove some soft tissues here. Was the answer nobody told me. What are the three structures that you ಅದು ಸಣ್ಣ ತಗೋ ಸಿರಿಂಜು 10 cc ತಗೋ. Can anyone tell now what is the three structures that we need to see before we actually proceed to do stapes surgery? Anyone? Orthopedic pick. Number one is a complete foot plate. Number two, horizontal part of facial nerve. Number three, the process pyramidalis, orthopedic pick.
The base of the forces pyramidalis is you should see.
See,
That will give you complete
if you
exposure.
cannot see what you are going to operate, see, the surgery is all about the exposure. That's all. If you expose properly, you will not damage the structure.
Yeah.
You will identify the structure. Otherwise, you will find a structure. Finding a structure accidentally is something different from you identifying it. So that is the principle of temporal bone surgery. See, temporal bone surgery is unique in the body that to see the structures, you have to drill the bone and expose. Whereas in abdominal surgery, the moment you expose the abdomen, you will see the bone. But the ear surgery is something different or unique in the body that you need to expose the bone to see what exactly you want to do. So now I see the three structures that I want to see. Number one is this is a complete foot plate I can see. This is a foot plate. This is a foot plate. Just above that is the horizontal part of the facial nerve.
There is some debris.
Yes, that is
Clean
what
that. If you clean,
I need a cotton ball for that. Now I can see the complete foot plate here. ತುಂಬಾ ದಪ್ಪ ಆಗುತ್ತೆ ಸಣ್ಣದು ಬೇಕು.
yeah, the facial canal is seen, but it's covered with some debris there superiorly.
ಸಣ್ಣದು ಕೊಡಿ. See, why you want to do stapes in this specimen is to understand the not only anatomy but the maneuverability. The more maneuver you do in stapes in the temporal bone, here, the more precise you become as a surgeon. That is very important. Not that you do a stapes surgery immediately after going back from here. No. See, after doing so many temporal bone, so many surgeries also, still every case is different. See now, I see the stapes foot plate. This is a long process of the incus, and this is a stapes. See now, the stapes is actually fixed in this patient. See this? I move the malleus. I can see the movement of the stapes, but not the stapes. I can see the movement of the incus, but not the stapes. See this? Okay, now I There is this specimen. You see here, there is a dehiscent facial nerve. This is a dehiscent facial nerve. Can you see this?
Your hand is coming in, JP.
My hand is coming. Okay, right. I will go
You have
to.
to change the angle little bit. Okay. Now we should be.
Is it focused for you?
Yeah, now it is focused. Yes. Good.
Yeah. See now, this is the cara tympani. This is the pyramidal process, and then this is the stapedius tendon. You see this soft tissue here. Can you see this one? There is a facial nerve opening is there, and facial nerve is completely dehiscent, and it is occupying the half of the foot plate. Can you see this pinkish one? See this one. So now, suppose if I am doing live surgery, I will think 2-3 times to proceed now. Okay, I will just close it and give you. If I am doing surgery for this patient, you can see the foot plate very clearly. I don't know whether it is focused for you.
Focused.
Okay. Yeah. Now, the first thing that we need to do is to do the see there is nerve here. I have already made a fenestra here. See that? Now, the moment I make a fenestra, the next job is to measure how much is the average Indian Western body. 4.4 to 4.5 or 4.25 is maximum. So now, next is to insert the pain. What we are doing is the reverse stepidotomy. So the step in step surgery that will give the result whether fail or pass is the fenestra. The fenestra can be made by a hand, fenestra can be made by a skeeter, fenestra can be made by a laser. Laser, to me, laser is the best one to make the fenestra. If you don't have a laser, the next best option is skeeter. Otherwise, your hand also can do the same job. See, all these years we have seen stalwarts. They were made only with the hand, not with the laser. Don't think that there is no laser. Otherwise, I would have done so much and all. But the best is to put the hand. Now, I take the piston and the loop has to be dilated a bit because the loop has a memory. So now before insertion, I take this and then dilate, give me alligator forceps. See, the delegates were sitting here. If you have any friends in England, all these micro instruments are disposable. They use once and throw. You can just tell them they can get for you. In OP also and inpatient also, they just throw it out after one use. We can use that for the dissection code. See, I held the.
But we have been using it for the last 20 years.
Gentleman gave me around 15 or 20 forceps recently.
Okay.
See, you take this. This is. I'm using all of them in my dissection courses. We have to reduce the ಸ್ವಲ್ಪ ಕಡಿಮೆ ಮಾಡಿ ಉದ್ದ. So that is how we should hold. And then attach to the long process of the incus. And put it one go, we can do that. But the only thing is, you must know how exactly to pour hacking. Just start here. 4.25. 4.25. This is measuring jig, it is there. The best measuring jig is actually our Indian ones may not be very accurate. If you want accurate, the Integra company is there, the Integra Life Sciences. They are very good measuring jig. You can trust upon them. See, stapes surgery is all about making the fenestra, that's all. If you can make a safe fenestra in the posterior 1/3 of the foot plate, then the all surgery is done. That is the only step that will decide all the complications and the end result of the surgery. The next is the done. See, one go. How you held it, how you take there, and how you put it. This is not the so many thousands of times I have failed before I put like this. Not once. And today I see all the younger colleagues, they are doing better job than me. When I was at PG, I have not seen temporal bone also. But today I see first year postgraduate who come to our course is exposing the patient now. I'm not, shameless to tell that. But you people are lucky to have so many courses and they are spending a lot of time and energy to get the bones for you. The next step is once we do this, so now we take a 45 degree pick and 45 degree pick. What is 90? Okay, right, no problem. I take this, then separate the incorostipular joint. See, gently. The step is like that. See, I separated the incorostipular joint. Can you see this movement? Okay, next is to cut the stapes tendon. Some people say that they cut the stapes tendon. You cut the stapes tendon, I cut the stapes tendon. Now I take the same 45 degree pick and see the pick of the stapes. See this? Just with a small, I fractured it and see I remove the superstructure. Can you see this? The plate has not come out. So now we stapes like this. There are another two ways. Number one is you weaken the crura with the 45 degrees, slowly scratch the, then it will become weak. Or you can use a crurotomy scissors. If the stapes is fixed nicely, you can do this maneuver. Okay. So now once this is done, so now you take a small soft tissue from the post-oral area and just keep this soft tissue, small bits of it around the here, the fenestra, so that there won't be any leak. That is the, we have completed the stapes now. So now, so far, any doubts you have, you can ask me before we go for the next one. If you have no doubts, that means there are two things.
Yes.
Whether I'm too bad or whether I'm too good.
Yeah.
Okay, anyway, no problem. So now the second exercise is done. Then next is we have to identify the next set of landmarks. See now this is a supramastoid crest. This is a posterior bony canal wall, and a vertical tangent you draw to bisect the supramastoid crest. Bisect means supramastoid crest is this much. You take half of it like this, bisect. That means you have a small triangular area here, what you call it as a suprameatal triangle or McEwan's triangle. Okay. So the idea of this McEwan's triangle is the principle of temporal bone surgery is from one known landmark to another known landmark by noting first and second structure relationship. That's all. Now I want to find the antrum. So the first landmark for me is what is the landmark that I have? Superior meatal triangle. So no section of madi. A bag ಬರ್ಸ್ ಇದೆ ಕೊಡಮ್ಮ ನಂದು ಈ ಬರ್ಸ್ ಎಲ್ಲ ತೆಗೆದ್ಬಿಡು ಒಂದು ನಿಮಿಷ ಒಂದು ಇಟ್ಬಿಡು ಇಂಥದ್ದು ಬೇಕಾದ್ರೆ ಕೇಳ್ತೀನಿ ಕೀಪ್ ಯುವರ್ ಬರ್ಸ್ ಅವೇ ಫ್ರಮ್ ದಿಸ್ ಅಲ್ಬೇಡ. Another suggestion to Prahalad, you can have bulb holder like this. You can keep the bus like this.
Yeah.
So that is 500 rupees to you.
No, although I'm used to this system.
No. For them, for you also, you can keep the bus like this, which will cost 500 rupees to you.
No, we have it.
You haven't?
We have it.
Decibels, it is available. You can use that, and it's a wonderful instrument.
Have it.
All right. This is the number.
Can you open Zoom and see what you're seeing
This
there?
is the number.
Just check
ಇದು
because it's not
Son-
coming on that.
So, there is a Mexican's triangle. The moment the Mexican's triangle is identified, so now I will open into the antrum in a systematic way. So now,
Every time you have to register. Oh, it's coming, ಅಲ್ಲ? Okay, okay.
ಇದು So now I will have small discussion about the bursts and drills later. See, this is the round burr they have taken. Yeah. Where is drill on ಮಾಡಿದ್ದಾರೆ?
We don't use
Huh?
we don't use conical burrs.
Okay.
It's a matter of rules.
See, the first cut is always made along the supramuscular crest like this. Fix ಮಾಡಿಲ್ಲ ಗುರು ಇದು. Okay.
ಶಾರ್ಟ್ ಬರೋದು ಸರ್ ಈ ಕ್ವಶನ್ ಬರಲ್ಲ
ನಮ್ಮ ಬರ್ಸ್ ತಂದಿಲ್ವಾ?
ಇಲ್ಲ no problem. ಇದು ಬೇಡ ಗುರು. No, you give me a short one.
ಅಲ್ಲ use our burrs.
No problem.
ಅಲ್ಲ ದೇರ್ ಶಾರ್ಟ್ ಬರ್ ಓನ್ಲಿ.
ಅದೇನಾಗಲ್ವಾ ಅದು?
ಇಲ್ಲ ಏನಾಗಲ್ಲ. ಯೂಸ್ ಶಾರ್ಟ್ ಬರ್ಸ್ ಓನ್ಲಿ. ನಮ್ದೇ ಯೂಸ್ ಮಾಡೋ.
Sir, no problem.
Use our burrs.
Okay. See, the longer the burr, okay, the more the wobbling. The shorter the burr, the more stable it is. The longer the burr, your hand lumbricals will get spoiled over a period of time. You will develop tremors. But when you use a surgical handpiece, see, mind you, this handpiece is not the one what you use. This is surgical handpiece. That is a lamb handpiece. So for this you require 70 mm or 7 centimeter burrs, whereas for a shorter one, 5 centimeters is ideal. So for this, okay, so what you have to do is, ಇದು ಸಣ್ಣ ತಗೊಂಡು handpiece.
We have only one uniform this thing.
ಹೌದಾ ಸರಿ, okay, no problem.
ಅದು we are used to this system ಅಲ್ಲ.
No problem. So my suggestion is, when
ಫುಲ್ ಒಳಗೆ ಹಾಕೋ.
right. See, can you see the teeth of the this burr is something different.
Short means what I mean to see the event. So you have the shaft of the burr is not too much outside. Okay.
See, the more number of flutes the burr has, the less the cutting capacity. So see now I made one cut like this, another cut just posterior to the bone canal wall, another cut like this, where it marks my sigmoid sinus here. So now the most important first fundamental thing you have to understand is, never try to lower posterior bone canal wall. I have seen when I do revision surgery, most of the people they have lowered the posterior bone canal wall, which is leading to secondary iatrogenic cholesteatoma. So always keep the cut behind this. So now see this cellular mastoid. I can see the movement of water here. Can you see that? If I am doing mastoidectomy for a tubotympanic pathology, I will not open the mastoid. I will stop here and put a graft. Okay. So now you open by removing this. See, the bone cutting test of the burr, you can practically see, is very less with the burr that has more flutes. For a beginner, this is very good. It will not jump. But whereas if you select a burr which is actually having
ಇದು ಹೋಗಲ್ಲ ಸರ್.
ನಾನು ಸ್ವಲ್ಪ ನಾನು ಮಾಡ್ತೀನಿ.
ಶಾರ್ಟ್ ಫಿಕ್ಸ್.
See, see how the ball is being removed. Hmm? The patient has more cells in the mastoid. It will be difficult for you to change all the cells if the patient has a cholesteatoma. Okay? This is cellular mastoid. So actually we take a very good cellular mastoid bone for the demonstration. We take the X-ray of the specimen before actually we give it to the faculty. So now I thank them for giving me a very good bone like this. So I am not in a hurry to just open into the antrum and systematically drilling all the areas to get into the antrum. So always have a very see my direction of drilling. When I am drilling along the dual plate, see my drilling. See this, I am not drilling like this. And another point that see, I want to do here, do keep like this and do like this. Always on the back, and then take your drill to a place where you want to work. Instead of that, don't try to do this. Don't do that. Okay, I am removing the bones in three directions. Number one is I am trimming the dual plate. Next, I am trimming the sinus plate. And I am trimming the posterior bony canal wall. And these three directions I am working. See this. I am not just blindly drilling a small hole into the master axle system. I am having a roadmap in my mind that I will do in the specific way. So now see this. You must know what are the different cells also and their names and the structures adjacent to that. See now, so suppose if you are not finding the antrum at all. So now then what is the way to get to the antrum? You just take the dual plate as your guide, keep on trimming that will take you to the antrum. Antrum, what is antrum? Is a nothing but a very big mastoid hair cell that is always constant. So now I come to the antrum. So before I go to the antrum, my job is to remove
Where are you, ma?
the contact cells around and
Okay.
then skin the distal bone canal.
Yeah, it's on the
And
floor.
I get some of the air cells
Take lift and
before I open the antrum. What are the air cells before we get the antrum? Can anyone tell? What cells will come across? What are periantral cells? Before you reach the antrum, actually, you will see the periantral cells. Okay? I am not yet open the antrum, but what I am doing now? Can anyone tell what is this? What is that? I am not jumping inside and opening the antrum, but I am rather making the swings wider. So when you do particle or you open the antrum, in a tubotympanic pathology, you don't require to know all that. But when you do surgery for cholesteatoma, you have to address all these things because you have to remove all the cells. The sound of the bird will tell you what is the structure behind that. Okay? You must understand the sound. I am the posterior bony canal wall and I am thinning the dural plate. Now let me again put myself as to where I am. ಸ್ವಲ್ಪ ಸಣ್ಣದು ಕೊಡಿ. ಹೋಗ್ತಾ ಇದೆ. Wash. Always keep on washing the area. So now I'm changing my patient's head position. Don't keep on operating in this position only. When you want to see the anterior part, tilt the patient's head away from you. When you want to see the posterior part, tilt towards you. Okay? All that we need to see now the total picture is changed now. One side, change the position of the bone. Bone. See now I will just now this is the time that I need to change my burr. Okay? Because I want to drill here. How do you take the call which bug that we need to use at a specific point of time? So now you are see here I want to remove this bone here. Okay? Now I keep my burr here. See this burr is touching some unwanted areas like dural plate. It is touching here, it is touching here. That means this is not the ideal burr for me. Suppose still I proceed and do, then I will damage the structures which are not actually supposed to be touched with that. So I take a small burr than that. Now see, it touches only here. See now see this burr, it has very less number of leaves. So the burr that has very less number of leaves has got 2-3 cuts. It cuts the bone aggressively. At the same time, it will jump and it will plunge inside. The problem with zigzag burrs is it produces dural dehiscences. And if you take a smaller burr, it will go inside a cavity, plunges also. So now I have almost come to the antrum now. So now I will just remove the cells and show you the. How do you know that you have reached the antrum? What structure will greet you? Can anyone tell? Dome up? Yeah, where is the dome? Here.
Yeah, seen at the depth, yes.
Give me ನಿಲ್ಲಿ ಕೊಡಪ್ಪ ನಿಲ್ಲಿ ಯಾವ ಕೊಡು ಏನೋ ಅನ್ಕೊಡು ಪರವಾಗಿಲ್ಲ. See now, see some obstructing here, I remove that. See, this is the dome of the lateral canal. This one. Okay, this is fossa inclusus. This is fossa inclusus. Okay. So now that means I enter the angle. So now this cell, this ball, you need to remove towards the attic. So this next step is the transmastoid attic. So this step all of us should master, because when you do surgery for a kidney disease, cholestoma, when the patient has a limited cholestoma, and then the attic, that is called as transmastoid athecotum. Yeah. Huh? I will show all them. See, what she asked is the solid angle or hard angle. If the bone between the three semicircular canals is the solid angle or hard angle. See now, how I am building here, please all of you observe. I am filling the posterior bony canal wall, and my direction of building is not, see this, I am building from the important structure to the unimportant structure. You should never do building from a unimportant structure to important structure. You should start building from below to the attic. See now, I see a new landmark here. Can all of you see? What is that? Smooth cut tip put. See, this is the lateral canal. This is the fossa incursus. You can see the fossa incursus is housed by the short process incus, body of the incus. Okay. So now suppose if I know this step, how it is going to be surgery? Then agitus will become patent. My results of surgery will be better. So now at this point of time, let us just discuss about the facial nerve a bit. So now where is the facial nerve here? Now suppose if I want to damage the facial nerve deliberately, I cannot do, because God has given one landmark, there is a fossa incursus, and you need to remove the incus, then go to the facial nerve to hit the second genu. Okay. If you don't know this anatomy, then you will damage the facial nerve. Even if you know the anatomy, sometimes facial nerve may get damaged because there is one condition called as, in a congenital anomaly of facial nerve, pronounced hump. The second genu will be more posterior. In those cases, we may hit the facial nerve, not in a routine patient. Okay, now I will open the attic. So why I should do this exercise is, if I am dealing a patient who has a limited articulostoma and I want to just get rid of with a intact canal tympanoplasty, I need to remove the disease in the attic without removing the posterior bony canal walls. This exercise is going to help me. So now what is the important thing that I will keep in my mind is, number one, the dura, tympani and tegmen antler. So now, to do that dura, the dura, as you go more anteriorly, it will lower than the tegmen antler. So you have to be careful enough not to damage the dura here. Okay? Diamond burial, another. Sorry. So now I keep on going in between these two walls without damaging the from below upwards, not from above downwards. Always on your drill and take the drill to the place where you want to drill. Please keep that in your mind and please register them so that, say, if I am in a big sleuth, okay, I can drive the car. I can get up and drive the car. Because We are tuned first gear, second gear, third gear, like that. See, this is temporal bone surgery is like a flying or driving a car. See now, I see now another important structure which has come now, or some people call as a, if you see from behind, it is called as two buttock sign. Some people call it as two buttock because is that now I see the head of the, this is the body of the fingers, head of the malleus. You can see this superior caudal and superior malleolar ligament. Here, this one. So now once I remove some more here, then I will go into the next landmark. That is what landmark is seen there anterior to the head of the malleus. Can anyone tell?
Yeah, I can speak loudly. Yeah.
What structure is there? Which divides the attic into anterior and posterior. What is that?
Now they answered, cog.
Cog, right. And cog will find two structure. Cog is above, below one structure is there, like that. What is that? Huh?
What is another important landmark in the middle ear? Yes, process
Process
calculation.
of your just below cog, which is a constant landmark, which will rarely get destroyed. Is that cog? So the cochlear farmers. Now I want even abdominalis. Can you see? There is an anti-attic space. So all of you should be able to do this exercise. So now we have completed 3 exercises now. 4. Please, loudly.
Grommet insertion, stepedotomy,
Don't speak.
stepedotomy,
Huh.
cortical mastectomy, transmastodicotomy.
Okay, now we are going to do extended cortical mastectomy. What is it? What is simple mastectomy or Schwartz operation? What is cortical mastectomy? By textbook definition, is exemplification of accessible mastoid hair cells is a simple mastectomy. But whereas when we do extended, that means inaccessible mastoid hair cells also we are going to remove. So that is called as extended cortical mastectomy. Accessible mastoid hair cells. Please remember, accessible means so at the end of the cortical mastectomy, both anatomically and physiologically, the ear linear cleft is normal like before. That means we are not disturbing the posterior bony canal wall at all. If you disturb any part of posterior bony canal wall, then we cannot call it as a simple mastectomy. Okay? So now I will remove all the cells now one by one. So I am removing what cells I am removing here from the What is the name of the angle? Another name. There is another name for this angle. Huh? Correct.
Yeah.
This angle. Okay, this is this angle. Suppose if I drill this angle, what structure will be damaged? Huh? Yes. I will be damaging the superior semicircular canal. So remove the cells. A lot of cells are there to remove now. Wash. ಇನ್ನೊಂದು ಬರ್ಕೊಡಿ ನಂದು Yeah. ಒಂದು ಶೈನಿಂಗ್ ಇದೆ ನಂದು ಬರುತ್ತೆ ತಗೋ ಹೊಸದೇ. See, you have to spend bigger one. You have to spend good amount of money for your burst. Otherwise, you cannot do surgery properly. ಅದೇ ಅದು ಕೊಡಿ. See, if you spend very less amount and do surgery with a faltu burst, what will happen is you will spoil your back. You have to operate for a long time, no? Your time also is gone. No, okay. See how my back is not breathing. See, it is removing the bone. See this. You just observe once. See, I am just brushing it like a. See this. Because I have spent very. See, we have some interactive session in between where I will be just telling you about all the bus and where where to buy the bus, which bus are good, which are economical, all that I will be telling you in one class sometime. ಬ್ಲಾಕ್ ಆಗಿದೆ ದೊಡ್ಡ ಕೊಡಿ. The gold standard bar or the bill system is the denier, what I am holding. Is the best one, but very, very expensive, but it will last longer. And the RPM, what I am using is the 40,000 RPM. Whereas the conventional marathon will give you only 15,000 RPM, rounds per minute. Okay? So do remove all the cells. Now, slowly I am getting into the new set of landmarks. After the lateral canal, now we are able to see some of the new set of landmarks. So what is the landmark that we see near the tip of the mastoid? Can anyone tell? What is the digastric? Very good. What is the digastric ridge actually?
This bony ridge which corresponds to structure outside. Digastric groove. Yeah, very good. Digastric groove.
No, digastric groove. What is the digastric ridge actually? How that is formed? Suppose if I give you a pen and paper, and then ask you to write few sentences about the digastric ridge, what you write? As a short notes, tell me. Huh?
Decision inside the restaurant side.
Ah,
Sort of
buddy, what? Yes, very good. So this is the inner flip section of the digastric groove, which houses the posterior digastric muscle. It produces insertion inside the company bone as a digastric groove. So what is the importance? Why should you know digastric ridge? What will teach you?
It's a landmark for vertical part of the facial nerve as well as stellomesoid foramen.
So now I am gently removing the hair cells on an important structure. What is that important structure that I find here? Heartburn in the breast canvas. If you have noticed now, I have not created a complication yet. That means I have not exposed any important structure. That is the principle. So you should not be in a hurry to remove whatever there comes between you and the bird. Okay, see. Now, still I want to do some facilitation here. See my direction of the bird. And just don't press the bird against the wing with the intention to cut very fast. That will cause number one, jumping of the bird. Number two, it damages your fingers. I told you lumbricals will get damaged over a period of time. Okay. Now see the direction of the bird. See, I am not using my tip of the bird to remove the cells, but I'm using the see, side of the bird. See this? I am removing every now and then and coming. I am not just pressing like this. Please see that. That is what you have to learn. I want you to learn the basic bird techniques. Without that, you cannot become a yeah. Atapa. See, if you are noticed, see this? The moment I don't want to do, I remove the pedal. See now again you see it is moving. Suddenly it stops. So this is called as brushless motor. The motors are two types. Number one is a brush motor. Number two is a brushless motor. What we use in the lab for a dissection marathon is a brush motor. That means, see,
Majority of ENT
see now,
India is this only.
the moment I remove it, it stops. That is what we want. But still, before it stops, it rotates for a while, which you actually don't want. That is a brush motor. So the brushless motor. Number one. Number two, use a see, check whether it is moving the clockwise or anti-clockwise. Because your birds, this one doesn't have that problem. Your hand is what you give, you have that. So that when the bird is moving in the anti-clock direction, it will not cut. You have to check that and then proceed. There's 2 points. Now, always use the, see this, I am moving my bird like this. See now, don't do like this. See, that can cause anything. See this? See, at the most, it may expose the important structure. See, when I build on the sinus plate, my movement of the bird is, see, along the long axis of the structure. Slowly I am see the sigmoid sinus here. Okay, see this, see my direction of breathing. See, it is always like this, not like this. Please note that. See, keep moving your bulb like a brush. See now, I am able to get the new set of landmarks now. That is the, I am getting the sigmoid sinus into view now. What is the structure here? Anyone? What is the structure? Sumbhashan. Now slowly I am getting into new set of landmarks. If you identified, so now I have almost skeletonized the plate. I will do some more of this. Then I have removed the China grounding cells. I have removed the perisinus cells. These are the perisinus cells. Now I am going to identify the digastric ridge. Okay. How the cells are divided into two groups. Number one is the medial, number two is the lateral group of tip cells. So after we do the complete removal of the cells here, now we will now focus on the posterior body canal wall to do another important exercise, that is a posterior tympanotomy. So now let me in the ಸಬ್ಸ್ಕ್ರೈಬ್ ಮಾಡ್ಬೇಕಾದ್ರೆ ಆಗ್ಬೋದಾ? Suppose if the lateral group of tip cells will get infected, what abscess the patient will develop? Anyone can tell? If the lateral group of tip cells will get affected, what abscess the patient will have? If the medial ones, what abscess the patient will have? Tell me that. So now this is the diagnostic page. Okay? So now I will show you some cells which are actually medial to ನೋಡಿ ಇನ್ನು ಕಟ್ ಆಗ್ತಾ ಇಲ್ಲ. ಅರ್ಥ ಆಯ್ತಾ? ಬರ್ ಕಟ್ ಆಗ್ತಾ ಇದೀನಿ ಪಾಯಿಂಟರ್ ಒಂದೇ ಕೊಡಿ. See, smooth curve. This is the digastric ridge. Can you see this ridge here? Hello. This is the digastric ridge.
Another
Picture something and say that it is a digastric ridge. It is there already. Sometimes you may without that and this is digastric ridge. Okay. The cells that are lateral is lateral group, medial is the medial group. So now, if I bring here, I will go into another structure. What is that? What bulb is there? Huh? Yes, that is a jugular bulb which will become sigmoid sinus. That is a jugular bulb. Okay. So now I will now focus on the posterior bony canal wall. Identify the place where the posterior temporal opening. So now I will keep on removing the cells and skeletonize the facial nerve here. Diamond ಬರಬೇಕು. ಕಣ್ಣು ಕೊಡಿ. ಏನು ಸೇರಿದ್ರೆ ಪರವಾಗಿಲ್ಲ. ಮತ್ತೆ ಹಾಕಿ. ನೀರು ಹಾಕಿ. So now what is the boundaries of my drilling here? Can anyone tell me?
boundaries of facial recess.
Uh-huh.
Now asking.
What? See now what happened. If I am using a burr which is bigger than the area that I am going to use, this will happen. Okay? Don't do that. All mistakes, whatever you want to do, section only, not on the patient. All mistakes, don't repeat them. Mistake every time. Don't repeat the same mistake again and again. Okay? So now, my now landmarks are fossa includes. Now I will identify the landmark before I build actually. Okay. Move cut for it. Yeah. Sundar section देखो. See now this is the fossa inclusus. Okay. So the facial nerve will be here. So now my boundaries are the superiorly facial recess is bounded by the fossa inclusus. Medially by the vertical half of the facial nerve. Laterally with the tympanic annulus. With the obliquity, you have carotid nerve. So now this is a triangular area where there are some cells are there which are of no use at all. God has created some cells there for the surgeon to enter the middle ear from behind, which are of no use. All useless structures are there which are named for the surgeon's sake. Cog, there is no function. Process cochlear formis, at least there is a fully will come. Cog, what is there whether God gives you or not? But it is acts as a landmark for you. I take the diamond bar, and now this is the fossa inclusus. Now I keep on. This is the area that I will be filling for some cell. What is that cell? Can anyone tell? No, ಸಣ್ಣದು ಬೇಕಪ್ಪ ಇದು. ಹೌದು. What is that cell? Sentinel cell. There is something called in
Steroid cell. Somebody answered.
answered.
Mm-hmm.
Okay. See this cell, the way posterior tympanotomy. That cell will be present even in a bone where there is no cell at all. So I keep drilling. So now the structures now at risk are number one is facial nerve, number two is the choriotympany, number three is the tympanic annulus. So while doing this, you may make a small burr in the extra canal. So but you have to be very careful to not to do that, and your shaft of the instrument should not touch the facial nerve. So because you will be concentrating on the tip of your burr, but whereas the burr will also touch the part that you actually don't want to touch. So that is the posterior tympanotomy. And now I will show you the moment you open the posterior tympanotomy, what structure you will see? Hello. What structure you will see?
IL joint. They answered. Yeah.
Include joint. If a soft tissue is there, that I will remove that, then you will see the incrostapial joint. Give me a needle. Yeah, simple. Yeah, can you see that? Included giant. What I'll do, I'll just make it little wider for you. The angulation you are unable to see. I'm able to see that. I will make you see now. I have deliberately put a small piece of bone. I have manufactured a small piece of bone left to the attached to the fossa inclusus. What is it called as? What buttress is that? Hello. Now can you see? Hello. Now can you see the piston that I placed there? The long crossover incus. See, this is the piston, and there is a long crossover incus. So what is this piece of bone that I have left here called as? Huh? Yes. Incus buttress is the, actually it is not a landmark present in the human body, but it is a surgeon has manufactured a small piece of that is called as incus buttress. Now you see this? See? Can you see the structures that you want to see here? See now. Is the incus buttress, facial nerve. So now if I come more here, I will take a bigger nerve than this diamond nerve and go inferiorly. What that procedure is called as? Huh? Yes, when you do the facial recess, when you do that,
Glomus tympanicum. The answer.
yeah, when the patient has a globus tympanicum also, you can do that. So now this is the, you can go somewhere also. Now the facial nerve is miles away. Don't worry about the facial nerve. So you have to not to be careful about the facial nerve. You have to be careful. Now there is a posterior tympanotomy. So now the next exercise that I want to do is the, now what are the things that I have to do more? Give me a diamond or bigger one. What is, have you heard of this endolymphatic sac? Not diamond. Gold color is that correct? Endolymphatic sac. Hello? Where endolymphatic sac is situated? Hmm? See, endolymphatic sac decompression was a surgery that was done very frequently some years back for the intractable vertigo. But nowadays, they are not doing that procedure for intact. See, not that intractable vertigo patients have come down, but there is a safe other modality of treatments have come in. What is that modality that has come to? Hello, can anyone tell? Huh? The safest modality nowadays for the is a chemical labyrinthectomy. So you can kill the labyrinth with just some few injections. So why do you want to do such a destructive procedure for a patient? So now that is why that procedure has almost become obsolete now. So now I am going to demonstrate the. So now I have new set of landmarks now. I will identify them. Probe. Proper. See, now this is the, all of you know, this is the lateral canal and this is the posterior central canal. I draw a line like this from the long axis of the lateral canal to bisect the posterior canal, with the posterior canal, like this. Now, just inferior to this line in the layers of dura, I will find my endolymphatic sac. See now, I will now skeletonize the dura plate. I am already found the dura here. Cluster knife ತಗೋಬರು round knife ತಗೋ. Now, this is the dura, posterior fossa. I will remove this bone. Can you see this one? Posterior fossa. I'll just expose a bit more. It will be easy for us to. ಕಡಿಮೆ ಹಾಕಿ. ಕಡಿಮೆ ಹಾಕ್ಕೊಡಿ. ಪಿಕಲ್ knife ಇದೆಯಾ? ಕೊಡಿ. The nonsense line is this. Just inferior to this, you see the. Can you see this? Here. Can you see this? If you want, I will open and show you. See this. Okay? See? That is the endolymphatic sac. Okay. Now we will trace this duct later on. Okay. So now I will do the next exercise that we want to do is the labyrinth, skeletalization of the labyrinth.
You want to finish retrofacial approach to jugular bulb before that?
ಮಾಡ್ಬೇಕು ಮಾಡೋಣ.
Yeah. You can
Okay.
finish that. Yeah.
That will not take much of our time.
Hmm.
I have already done so much. I'll just okay. Well,
Yeah. Almost little more.
so many cells are there. Now you see the that is a sigmoid sinus, and you can see lot of cells behind the sigmoid sinus. This is a jugular bulb area.
Center now.
I think I'm using a higher magnification.
Little, yeah.
Yeah, now it's
Now
okay
it's
for
okay.
you. For me, higher magnification is better for demonstration. For you, this is okay, no problem. Okay, now see, you can see this is the jugular bulb area. It is something like this. And
You can also complete this thing.
uh,
Facial now decompression.
uh,
You can complete before going for this thing.
okay. No, if I want to make the facial nerve, then I have to do a canal down. That is why I just want to open the labyrinth and then go for that. Complete facial nerve once for all. See, the cells in the temporal bone is left. Now there's already greeting you there. Giving wash, nice wash. See, the anatomy is quite clear to you now. Drill ಕೊಡಿ. Drill. See now, see, ಒಂದು smooth curve prop ಕೊಡಿ. This is the lateral canal. What is this structure here? Huh? Right, this one, man. Superior is here, no? This is a posterior canal. So now I want to skeletonize the superior canal and just open the labyrinth. Okay? Where the superior canal is situated? Where the superior canal is situated? What is the other name for superior canal? So when the lateral canal is called horizontal, what is the other name for superior canal?
Anterior canal.
Yes.
Hmm.
See, if I remove all the cells, what you left with is the labyrinth only, no? That's what I am doing now. See, I am removing the supralabyrinthine cells here. Slowly, I can see my superior canal. See now, can I see superior canal? See? Hello? Yeah, you say yes or no. Now I'll identify the. See, before you actually open the canals, you have to identify them. Otherwise, you try to create some and then call it as a labyrinth. You see, this is the lateral canal. You can see this is the superior canal, complete turn, and this is the posterior canal. Okay. So now what I will do is I will just join all the canals with each other to make it as a labyrinthectomy. So how many openings are there? Into the, how many openings are there in the labyrinth? Tell me please. There are 5 openings into the labyrinth by 3 canals, and one is a crush commune is there. ಇದಕ್ಕಿಂತ ಸ್ವಲ್ಪ ಸಣ್ಣದು ಕೊಡೋಣ, ಕಟಿಂಗ್ ಬರು, ಕಟಿಂಗ್ ಬರು. ಕಟಿಂಗ್ ಬರು, ಇದಕ್ಕಿಂತ ಸಣ್ಣದು, ಅದು ನಂದದು, ಇದು ಇದಕ್ಕಿಂತ ಸಣ್ಣದು ಬೇಕು, ನಂದ್ರಲ್ಲಿ ಇರುತ್ತೆ ನೋಡು. Right, there's a correct one. So now the first canal that I have to open is the, why we get the fistulas of the in the labyrinth, why only the lateral canal is seen very often? Tell me why. Can anyone tell why the fistula occurs only in the lateral canal? Okay. Because it is more superficial than anything, no? That is why
Yeah,
fistula is very common. Because other canals are very deep. See?
yeah, this was discussed during lectures also. They are situated kind of in a staggering way, where lateral semester canal is lateral most. Okay. After lateral semester canal, the posterior semester canal 2 meter medial, and then further 2 millimeter medial is the anterior canal. But sometimes the ampullary end of the anterior semester canal also can involve in cholesteatoma fistula because of its close proximity to the attic mainly. Huh? Hmm. Yeah, if yeah, JP, you want to talk about this thing, cholesterol fistula during management of fistula during cholesteatoma surgery? Yeah.
See, when you come across a fistula of the lateral canal, the patient will have what is called a fistula sign, and the patient will have giddiness when you try to clean the ear, or when they go to the, now I am pulling under the superior canal. Can you see that?
Yeah.
So now I follow that. See, I am not here to just create the fistula or the opening here. See, I am following the canal. See this?
What is that point is also called? Ampullary end of superior semester canal. One name we gave. Mike's dot. Yes. Mike's dot. Yeah.
See, I am just following the long axis of the canal here. If you have noticed here, I am not creating a hole. See this? Can you see that? You can see membranous labyrinth also inside. The superior canal, you can see very clearly the membranous labyrinth also inside. So now I will leave here, and then now I will put the amplitude of the posterior canal. See, the amplitude of the posterior canal is very medial to the facial nerve. Okay, I am going drilling. My drilling is. So can you see the posterior canal I opened here? I'm just following the anatomy. I'm not opening any new things or a new openings with my birth. I'm just following the arch there. That will take me to the place where exactly we want. One of the toughest bones in the human body. I'm drilling here. That is the photic capsule.
Yeah. The otic capsule, a bone covering the semicircular canal, a labyrinth, is one of the toughest bone in the body. In order it to be get fractured, the injury has to be very severe.
Now can you see the crust coming in? Can you see that? Yeah. Now I have completed the labyrinthectomy, but I need to just open the anterior end of the posterior canal. Okay, that's it. Now you take 10 cc syringe and saline. See now, the soft tissue here, if I do like this, all the saline will come like a fountain, 5 fountains. So now this is the soft tissue here because membranous labyrinth is here. I remove this membranous labyrinth. Can you see now? This is the membranous. You can see membranous semicircular canal very nicely like a plane. Can you see this? Yeah. Now we can, once we remove this bone, we can show you the endolymphatic duct also joining the sac here. See now, if I suck here, everything will come. See? So that is the labyrinthectomy. The next exercise is now show the canal wall and trace the facial nerve. Okay. What is the time? Time.
It's 11:20.
How much time we have taken now?
Approximately about 40 minutes.
Hey, 1.5 hours, I think.
Yeah, we started at what time? Sorry. We started 9:30, alla? 9:45 we started. 10:45, yeah, 1.5 hour. In another 10 minutes, we'll have tea break.
Yeah.
Tea is on the way. Yeah. No, take your time, no hurry.
In labyrinthectomy, we don't do for day-to-day practice, but at least we will have the feel of doing the anatomy, seeing what exactly we are talking
Yeah.
about daily. All those things we learn. So now I will do the
JP,
ah,
the tea has come. We can we have a
stop for 10, yeah.
yeah, we'll have a 10-minute break.
Yeah.
Yeah, okay.
So it is always a good idea to give break for every 1 hour break when you do dissection, so that not only the machines but also your mind also would have become hot. So all the machines have to become cooled down along with your. Yes, sir. Okay, right. Okay. Dissection ಮಾಡಬೇಕಾ the photo
ಇದು ಸ್ಪೇಸ್ ಇದೆಯಲ್ಲ ಇದು ಅದಿರಬಾರ್ದು ಅದಿದ್ರೆ ಯಾವ ಸೆಲ್ಸ್
ಸರ್ ಈ ಶೀಟ್ ಎಲ್ಲಿ ಸಿಗುತ್ತೆ
ಸರ್
ಸರ್ ತಂದಿರ ಸರ್
ಬಹಳ ಈ ಶೀಟ್ ಹೊರಗಡೆ ಹಾಕಿಲ್ಲ ಇದು ಇದೆಲ್ಲಿ ಸಿಗುತ್ತೆ
ಇದ ಇದು ಬಾಲ್ ಅದು ಅದೆಲ್ಲ ಮಿಕ್ಸಿಂಗ್ ಆಲ್ಸೋ ಅಮೆಝಾನ್ ಸಿಲಿಕಾನ್ ಸ್ಟೀಲ್ I tell you, time management lecture ತೋರಿಸಿದೆ ನಾನು ಯಾಕೆ ಅಂತ. I showed you this why you use sheets on time management. Because you have colors for blue, green, yellow. All the sharp instruments and the thing. Okay. Less commonly used instruments, more commonly used instruments. So, Martha, okay, they know they don't search for it.
that's why I want to ಇದು
We can clarity.
Is it? So maybe my spectacles are different for the distance vision. Microscope on ಮಾಡಿ. Suction. Knife ಕೊಡಿ. Forceps. So now what I am going to do is now I will remove this posterior bone canal skin here. Okay.
Yeah. Like this, sent mine. But for you, if you want to return, then the euro plate for you. You will get them to go. Oh, sick. Give us straight. Better. Yeah, I know. Better. If there was something similar to me, I don't have actually. I will stay there.
So now I will take a. Now all this thing we have done in the closed cavity now. Mic, huh? Okay, mic please. So now what we are going to do is now to remove this posterior bony canal wall. Yeah, okay. Now I'll just quickly take out this posterior bony canal wall. Now this posterior bony canal wall I actually call it as a different places. It is called as a different names. So now once we break this, okay. Now let us define those terminologies without any confusion. See now this bone, what is bridging the ossicles or the part of the bony canal wall that is lying lateral to the agitus adentrum is called as the bridge. You know what is bridge? It is bridging two gaps, the bridge. So this is the bridge. So the bridge is that part of posterior bony canal wall that is lying down just lateral to the agitus adentrum. Okay. Now let me remove this skin, then you will get the clear idea. No, it's correct. Okay. What's so bridge is that part of posterior bony canal wall that is overlying the agitus adentrum or it is bridging the ossicle. That is a bridge. So the bridge has to be broken and the ridge has to be lowered. Give me the scissors. Curate. Block ಆಗಿದೆ ಇದು. So the terminologies, most of the times it will be asked in the Viva, and again, same new answers will be given by the postgraduates, not the ones that are given in the book. Their own statement they will make. What is bridge means? So it is nothing. It is mathematics. So there is no your own definition. You now see, this is the posterior bony canal wall. So now, can anyone tell what is Bondis operation? Hello? Needle ಕೊಡಿ. Bondis, what is Bondis operation? Hello? This is Bondis operation. Now you tell me at least what is Bondis operation? Modified radical mastectomy done for a limited cholesteatoma. When the cholesteatoma sac is just lateral to the articular chain, that means the disease is very, very limited and you don't require to remove the ossicles. So when we remove the ossicles is when the cholesteatoma is lateral to the, when the cholesteatoma is medial to the ossicles, we will remove the ossicles. Otherwise, we don't remove the ossicles in the cholesteatoma surgery. Suppose if the patient has, give me the, yeah, to make you clear or more understand, to understand in a better way, I am now going to sacrifice the cauda tympani and part of the tympanic membrane to make you more understand. Now, give me a needle. Suppose if the patient has aortic cholesteatoma that is lateral to the ossicles and extending up to here. What I will do, I will just open the mastoid antrum and do transmastoid or inside out aorticotomy, and I will remove all the disease. Suppose if the disease is going medial to the ossicles, then I will remove the ossicle to see what is there medially. Suppose if I am very confident that there is no disease medially, then I will not remove the ossicular chain, and now I put the graft now. So this will become Bondis operation. Bondis operation, that means to say that it is done in cases where there is a aortic cholesteatoma with a limited disease that is lateral to the ossicles and the ossicular chain is left intact. But now what is the major drawback of this procedure is, while you are drilling, suppose if your drill system touches the ossicular chain, then the patient will develop sensory neural hearing loss and the purpose of whole surgery is defeated. So now see, this is a short process of the incus, this is a long process, so the stapes is there, and that is the malleus. So now I am done with the what is called as a Bondis surgery. In my practice of 28 or 30 years now, I have done about 20 or 30 so far, Bondis operations so far. I have not done many. So now I will remove the incus along with the stapes piston. Take the piston and incus, don't throw it. Now, to remove the malleus, it has an attachment. What is that attachment and where it is attached? Now I am cutting this confidently. What I cut now? Which muscle I cut? The tensor tympani, which is attached to the medial part of the neck of the malleus, are removed. So now if I am doing open cavity, the most important step is, most of the beginners are left, they leave this part of surgery to see this one, to don't remove this bone. I have noticed when I do revision surgery, I found that this bone is not being removed by many, leaving a disease here, number one. Number two, if it recurs, you cannot see. So now the idea of a MRM is to make this anterior wall flush like this. Number one. Number two, when you load here, you see the dura will progressively come lower as you go. That you have to keep it in mind. So now keeping that in my mind, now I will remove this bone to expose that part. Okay? See, remember, an ideal cavity should be exposed, and we know what are the places where we are likely to leave the disease. This is one of the area is anterior epitympanum. That is what is the area that I showed there. So now you have to make that into a single line. This one. आजकल पनीर रखें. Where are? Okay. Change it into a small burger. Diamond burger ನೋಡಿ. Diamond burger ಕೊಡಿ. Diamond burger ಸಣ್ಣದ. Yeah. Section ಕೊಡಿ. The moment you break the bridge, your bridge is broken. Give me a pointer or something. This is the posterior buttress, this is the anterior buttress. See, this is the bridge. See here. This is the bridge. You've broken the bridge. This is the anterior buttress, this is posterior buttress. That's all.
The anterior buttress is confluence of the bone formed by superior canal wall and the root of the zygoma. Posterior buttress is where is section tip is there. That's all the posterior buttress. That's the bone of the posterior canal wall or the facial canal. Posterior canal wall, bone of the. So bridging, bone bridging both the structures is the bridge. Yeah. Yeah, what is drilling is that fog area. Yeah, that's the anterior attic. He has exposed the complete anterior attic. Yeah.
Okay, now I remove this part of the posterior bony canal wall.
Yeah, that is what is drilling is the posterior buttress, also known as ridge.
See, in the MRM, the most critical point is this one. If you don't do this sufficiently and lower it sufficiently, this part you cannot see. Number one, whatever meatoplasty you do, that flap will not go and sit properly. That it will stand like a pillar there, and then you are left with a lot of debris in the postoperative period. So now I know where the facial nerve will come. So now, what are the important landmarks for the facial nerve in the middle ear and how they are related? So now this being a facial nerve symposium. So now can anyone tell what are the landmarks here? We know very well that when we are doing stapedectomy or small fenestra stapedotomy, we have seen the distant facial nerve there. Okay.
So that cochleariform process and now the diastatic ridge and the lateral subsect canal. Three important landmarks for the facial nerve that show that cochleariform process, JP.
Yeah, now you give me cluster snipe. Scissors for it. So this is a cochleariform process. I remove that.
Yeah.
Cluster snap करें. See now, can you see the horizontal part of the facial node adjacent here? Hello?
Hmm. Yeah, fine focus. Yes. Illa, not focused.
Okay. That's all I can do for you. That's the final. See, this is the process cochlear formation. You can see the facial nerve just adjacent there. Can you feel the soft tissue here? Why it is adjacent
Oh,
in
yeah.
that area most of the times is you must know what is the
This is
you know, this is the pyramid process. So now this second gene here.
Ah.
See this? It has become more superficial here. So this is the facial nerve.
ಐದುವರೆಗೆ
Can you see the
ಬಿಟ್ಟು
separation here?
ಬೇಡ. Okay.
So now we will trace this. This is the facial nerve. See, this is the one. It is coming here, and then it is taking a turn, and then going like this. So now we will trace that towards the. Before we open, we will skeletonize that, and it will be most of the times it is flush with the. So here we have at the anteriormost part of the. Turn it like this. See how now we are discussing about this digastric ridge. Okay, where the digastric ridge anteriorly will merge with the fibers of the facial nerve sheath. The periosteum will. That's what we are going to see now. Now, can you see the periosteum here? Hello? Yeah, now I'm tracing the. So, this is the facial nerve here.
Yeah.
See, as the facial nerve is descending towards the stellum foramen, it will become more superficial. It
Now
is.
now you can observe how beautifully he has done that barber polling,
See, that is the periosteum of the. Can you see this periosteum here?
Yeah.
See, now give me the round knife.
It's looking like a fresh bone periosteum.
See this one, the periosteum. And here is the facial nerve going. ಸ್ವಲ್ಪ ಸಣ್ಣದು ಬೇಕಾಗುತ್ತೆ ನಮಗೆ ಇದು ಡ್ರಿಲ್ ಹೌದು. So this is the second geno, this is a facial nerve. I have not see how the facial nerve is related to the lateral canal. The lateral canal is facial nerve is anterior and the lateral canal. See this is lateral canal. See this facial nerve is coming like this and making a turn here and taking like this to the exit here. So see now, this is deep here and this is superficial here. So when you do canaloplasty extensively in this part, sometimes you may expose the facial nerve. So careful not to damage the facial nerve. Can you see the shadow of the nerve? Hello? See, this is the nerve going like this. Round knife, correct? I'll just dissect it out without, but I will not open the sheet. Can you see this is the facial nerve here? See, it is going and getting merged with the anteriormost part of the. Can you see this? This is the digastric ridge and this is the periosteum. So this is the vertical part of the facial nerve, the second geno, and you can thin this. I'll drill out and then. Round knife. That was the recent facial nerve and this is the sheath of the facial nerve. I just opened there and these are horizontal parts and this is the geniculate ganglion. So now I will dissect it some more and you will think that the facial nerve is going anteriorly, a branch of it. See? No, sure. No. So now what is this canal here? This one, this canal?
Canal for tensor tympani transferring.
Tensor tympani. And just above that you can see this is the greater petrosal nerve going. Can you see this greater petrosal nerve going? I will just open and show you. What is the greater petrosal nerve? Where it goes and joins from middle ears.
It goes and joins a ganglion.
See, it goes again into the middle cranial fossa to the superior tympanic canaliculus. It enters, it travels, and again it leaves the middle cranial fossa by which foramen? Ovary. Is it correct? No, no, no. Superior tympanic canaliculus, and then it will come out through the foramen. So this is the greater petrosal nerve, see, going anteriorly. This is geniculate ganglion. Can you see this nerve going like that? See?
Vidian canal.
This one. So now this is the middle part of the facial nerve. So now I will so what is left now is to do a internal automatus.
Yeah. See, in order to do complete labyrinthectomy for Meniere's disease, we had not only open the canals and drill the canals, we have to remove all the sensory epithelium in that.
Hmm.
Even little sensory epithelium remaining also, patient may have persistent symptoms.
Now you appreciate the crust coming here.
Crust coming here, common crust.
So there is a arch of the C, complete superior circular canal. So now what I will do is, I will remove the labyrinth and now I will go to the internal artery meatus. So now what are my new set of landmarks here is here.
So that subarcuate foramina is seen under the arch of superior semicircular canal.
Now see this,
Under the arch of superior semicircular canal, subarcuate foramina and subarcuate artery is seen.
see that?
Yeah, yeah.
1 minute. Needle kore. Now you see another landmark here. So this is the subarcuate artery, the end artery, this one, and this is the vestibule. Can you see the vestibule?
Hmm.
Yeah. Now, 1, 2, 3, 5. Very clearly you can see. So now quickly I will remove the canals and open the internal artery meatus. So now what are my landmarks for internal artery meatus? Can anyone tell? What is internal artery? Few lines about internal artery meatus. Where it is situated? Very clear now. See now? Very nicely you can see the crus coming going into the vestibule. See, whenever you see a blackish epithelium, that is nothing but vestibular epithelium. Okay? So now I will keep
Yeah.
lateral canal, ampullary end, and the superior canal ampullary end, and to identify the nerves later on. Yeah. So now my new landmark is, give me the needle korappa. Needle kore. My new landmark is this. What is this? This is vestibule, okay? Where the saccule and utricle are here. So now this is the foot plate. See this? I will palpate the foot plate from below upwards like this. See this? Can you see now? Yeah. So now keeping this as my see? Yeah. So now keeping that as my landmark, now I will drill 70 degrees around this vestibule. Now open into the internal artery meatus. So for that I require a smaller cutting bur than this. Or smaller cutting bur kore. ನೀರು ಹಾಕಿ ಸಣ್ಣದು ಕೊಡಿ. So remember, we pick the internal artery meatus from behind. So that means anatomy will be reversed. What you have in your mind is different from what you see now. So this is the canal. I want to preserve that bone so that I will identify the nerve that is going to the so now I am drilling in the 270-degree direction all around the vestibule. You know vestibule I have identified already. One minute. I'll just show the endolymphatic duct. So can you see this card like thing here? Can you see this? Can you see this card here? So this card is the endolymphatic duct. It will go like this because we have removed the trough of bone. You are unable to see the so you have to keep on pinning this bone. So now suppose what is fundus and what is porous? What is fundus and what is porous? Hello. This is fundus. If I just open here and this internal meatus, but I want to open it all around. If I just penetrate in one moment, I will be in internal meatus. I can do that, but I don't want to do that because I want to open it from behind by incising the dura of the internal meatus. Okay. So that is the reason I am not opening. I am not in a hurry to open also. Okay. So now I will open it. See, here surgery is nothing but patience. You should have a lot of patience. Lot of patience, and then you should, if you are in a hurry, don't do the surgery. You want to go to a function, or you want to go to a party, or you want to go somewhere after doing your surgery, don't do all that. You postpone everything, only never keep time frame for surgery because you cannot finish surgery according to your choice because the disease will dictate you as to how much surgery you have to do, what you have to do. Okay. So now I have almost cleaned the internal canal sufficiently, and now I take a diamond bar to expose the dura. If I still use a cutting bar, I already entered the internal meatus at one point. If anybody have noticed, have anybody noticed that I entered internal meatus?
Yeah, the dura.
Yeah, I have just entered there, but I have not incised it. But still, I don't want to do that unless I expose it to the maximum extent possible. Okay. So now, can anybody tell what are the contents of internal meatus? Hello, madam. Yeah, at the end of this program, in between we'll have some, if allows, I want to have interactive session with you. I'll ask some questions, every one of you, what you have seen, same things, to make me understand that how much I have to improve. If you cannot answer, that means I have not taught you. So that is what I want to improve myself. So for that reason, we have a small interactive session. So what are the contents of the interactive matters? What are the contents of the interactive matters, please? Yeah. Apart from that, I know you will answer all that, but I want something more than that. I want to prove that you don't know the answer. Then only my ego will be satisfied. Examiner, no? Yes, Rancha Paika, number one, number two. Very good. Internal artery and singular nerve. So because if you answer everything, I will get angry. As an examiner, no? Examiner, so you should hesitate something so that he will be, delighted. So now I just open the. Oh yeah. So because of the time constraint, now I have to use a cutting bar which has actually done something which I don't want to do actually. If there is a lot of time is there, I can slowly do because we have to give you a lot of time for you also. I have to use a cutting bar here. Sorry for that. And now, okay, no problem. And now give me sickle knife, curate, correct. So now I opened it, a part of it, and part of it I will. The picture clear to you there? Okay. Sickle knife, curate. Give me a sickle knife now. Scissors ready ಇಟ್ಕೊಂಡ್ಬಿಡು. Yeah. So now I have already my cutting bar. Now so I'll just incise it. See this is the dura of the. Can you see the dura? Yeah, I'll cut off this dura. Reception ಒಳ್ಳೆ ಕೊಡಮ್ಮ. Yes. ಇದು ಒಂದು ನಿಮಿಷ. ಇದು remove sickle knife, sickle knife. This is the first nerve that we come across in the bundle. It should be the superior vestibular nerve. Can you see this superior vestibular nerve? Hello? And the inferior vestibular nerve here. Can you see this? Now, the superior and inferior vestibular nerve. And now I will expose the facial nerve. See this one, can you see this facial nerve? And the more thicker and the of all the nerves is the cochlear nerve. I can see the cochlear nerve here. Can you see this cochlear nerve here? This one? Okay, I will remove the both the nerves for you then to show that this is superior and inferior I am removing. Now can you see? Remove the superior vestibular nerve. I am sorry, we need a cutting bar here. I cannot use it, but sure it correct. Yeah, sickle knife. Now I will go to hypernerve to show you the nerves that I wanted to show you. So now I remove the superior vestibular nerve. See, this is the. Now can you see? This is the facial nerve, this thick one, and the cut portion is the superior vestibular nerve. This is the inferior vestibular nerve that I have cut it here. Now can you see this one, thick one? This is the cochlear nerve. So this cut portion of the superior and inferior vestibular nerve, can you see this is the superior and inferior, and this is the cochlear nerve going anteriorly. Now this can you see this facial nerve here? Yeah. So now I will trace the facial nerve and open the labyrinthine segment. There ends our demonstration.
No, we'll do the modulus drill out also, and we'll see the internal carotid anatomy also anteriorly.
Okay.
Cochlear drill out, cochlear drill out. We have still some time is there, and we'll finish lunch and then go down.
Now we can anatomy. Now I will remove this portion of the. Just follow the facial nerve gently. They are cutting the diamond bar. What is physical neck of fish? Can anyone tell? This is the bench bar. What is the physiological working neck of fish? Huh? Correct. See, if you see the anatomy of the facial nerve is unique that it travels all the way in the body canals. But if you consider a body canal as a pipe, in a facial nerve runs in a pipe, it occupies the in the available space, 83% of the space it occupies in the labyrinthine segment. Then it occupies 73% in the horizontal segment and 63 or 65% in the vertical segment. That is what the studies have given in one neurology book I read. So wherever a small space is there for the edema to occur, there the facial nerve will be affected more. Okay? See now you see very clearly the superior nerve. This is the superior vestibular nerve supplying the ample of the superior canal. Can you see this? This nerve. Now this is the facial nerve. Can you see this facial nerve here? This one can you see? Yeah. Now we are following the vestibular nerve.
Aji, PAP, Bale, do one thing. JP, take that frame to center. That PAP is, yeah, okay. ಇಲ್ಲ. Okay, ठीक है ना. ಆ PAP ಕೆಳಗ್ ತರಕ್ ಬರುತ್ತಾ ಇವನೇ ಈ ಕಡೆ ಕಾರ್ನರ್ಗೆ ಕೆಳಗೆ ಹಾ ಓಕೆ.
Now we unload the labyrinthine segment. Just within few minutes you will see the now can you see the nerve taking a turn here? Can you see? Hello? Now I don't know how the vision is because my spectacles, what I use for long distance is different. I am unable to see.
Okay.
Huh?
Yeah, I can understand. You're seeing through the specs, ಅಲ್ಲ?
Reading glasses.
But for us, picture is very, very clear.
Right?
Yeah.
See, this is the shadow of the nerve. Can you see the shadow of the nerve here? This is the labyrinthine segment, and this is the first genu here. Can you see this first genu?
Yes. Yeah. Third of focus, little bit focusing is required. Yeah.
Okay, now?
Yes. Little more. Okay.
I have to drill some more here. One of the most difficult exercise for anyone is to expose the labyrinthine segment of the facial nerve, which requires not only the fine instruments and 1 mm, 2 mm, fine curettes. You cannot just remove. Here. Yeah, now I can open it and show you. Curate ಕೊಡಿ ಸಣ್ಣದು. No. Now can you see the nerve here? No, I'm not done. Thickness. Now I've exposed the labyrinthine segment of the facial nerve. See, this is the. I'm lifting the nerve here. See, this is the. Can you see this nerve here? Hello.
Yeah.
This is the labyrinthine facial nerve. Going to the small canal. I'm lifting it now. Okay. And making a star turn here. See, this is the first genu. Okay. See, can you see the first genu? Yeah, this is the first genu. Then turn like this. And then this is the horizontal portion of the facial nerve and vertical and then exit. Is it now clear to you? Or you have any doubts? And just remove this nerves here so that again you will orient. See this? Okay, this is the complete facial nerve. Can you see this? This is the meatal portion. This is the intracranial portion, meatal portion, intracranial, and all the segments you can see. One, how many segments the facial nerve has? What is structure sality? Yes, all these three components will join here. So you see these three components. Okay? Join and then form the complete facial nerve. So this is the meatal portion, this much. It will become meatal portion. And this is the entrance of the labyrinthine portion. And this is the labyrinthine portion. This is the genu. I'm lifting now. Can you see the labyrinthine portion here? Then you take a turn here. Then, okay? Any doubts? So that's about the complete exposure of the facial nerve, the intracranial, intracanalicular, labyrinthine, first genu, horizontal, second genu, and the exit. Okay? So thank you very much.
Hmm?
You want me to show the carotid?
Carotid, ಇದು cochlear drill out.
Cochlear drill out you show.
Okay.
I will show the carotid if you want.
Yeah.
Or you can do this, no problem.
Yeah, okay.
Yeah.
Okay. Come.
Thank you very much
Yeah.
for the opportunity. The bone is very good. So where you should show the entire facial nerve. You can see the
Yeah. Come.
and you have to see here, what are the anomalies of the facial nerve? Number one. Number two, what is the blood supply of the facial nerve? And what is the space available in the why edema occurs? Why you should do always labyrinthine portion only decompression? What is the discrepancy of the blood supply? Each segment has a separate blood supply for the facial nerve. So that is the the anastomosis will be more near the labyrinthine portion of the facial nerve. So that is why the edema more there. So all that we have to read with the over.
ಊಟ ನೋಡ್ತಾರ್ರಿ. ಕೊಡ್ ಗ್ಲೌಸ್. Yeah, JP, thank you very much for that wonderful demonstration of all the steps starting to end. Okay, there's some more last final steps. So, okay. Yeah. Section tips ಕೂಡ 18. Course, ಇದು ಕೊಡು. ಸ್ಮೂತ್ ಕಡು ಕೊಡು.
Yeah, now we are very clear now. Sir, I have unable to see that the need to see when you use the progressive gases. And again, it's small put of for you. When you are using microscope and operating, please see,
Okay.
number one, you have to always use the reading glass. Don't try to adjust the glass. We are using a progressive glass also. It is difficult for you to focus on the progressive glass. You always have reading glasses for microscope.
Yeah. Okay.
Very important.
Hmm.
Now I can see very clearly, yeah.
Yes. Okay, this is the labyrinthine part of the facial nerve shown beautifully in the first genu. The superior to this portion, a air cell is going here towards the petrous apex. Okay, this is the supracochlear anterior approach to petrous apex, one of the approaches. Okay, and here below the posterior sensor canal here and between the jugular bulb, we can drill here. This is the infra labyrinthine approach to the petrous apex. Okay, that is one other approach. And also we can go here below the cochlea. Okay, we drill some more here the hypotympanum. Below the cochlea, also we can go to petrous apex. That's the other route you can remember. That is infracochlear approach. Okay, and yeah, drill kodu. Cutting. Small, medium arc, 3 mm. ಅದಕ್ಕೆ ಸ್ವಲ್ಪ ಹೇಳಿ ಓಕೆ ಇದು ಕೊಡಿದ್ರೆ ಓಕೆ ಬಟ್ ಐ ಆಮ್ ಗೋಯಿಂಗ್ ಟು ರಿಮೂವ್ ಸಮ್ ಮೋರ್ ಇಲ್ಲಿರೋದು ಇಲ್ಲಿ ಕೊಡು ಡ್ರಿಲ್ ಕೊಡು ಇಲ್ಲಿ ಬೇಕು Yeah. Okay. Goodness. Okay.
Before all these, you are like, that should be, okay, should not have that thing. Should not have the that thing. Should have kind of it. And do them back to the. And you can say, what times you're going to spend on money, that is, not you. So, not comment or wrong neck. What is
ಮೇಲೆ ಆಗ್ತದೆ ನನ್ನ ಮೇಲೆ ಹಿಂಗಿಲ್ಲ ತಗೊಂಡ ನೀರು ನನ್ನ ಮೇಲೆ ಬೀಳ್ತಾ ಇದೆ
back pain is ostrich, but
ಹಾ ಓಕೆ so this hypotympanic cells here I'm drilling this and also I'm doing some more canaloplasty posterior of the stenotic canal I'm drilling okay and this is the carotid canal okay it is immediately adjacent to the cochlea here okay. That is the carotid canal, and it's going here. This is a dissection tube is here in the inferior aspect, and the floor of the dissection tube is the carotid canal. With carotid canal, it ascends as the ascending part of the carotid canal and becomes geno here and goes anteriorly as petrous pet of the carotid canal. And here inferior to the cochlea here, this is the subcochlear air cell system. Okay, you can see there is a air cell tract going here to the petrous apex. Okay. And this is the subcochlear canal. I think that Sujan, you had asked me what is subcochlear canal, okay? This is the subcochlear canal. It can be sometimes very deep. There are 4 types of subcochlear canal. There is a paper there. And one of them, it goes to petrous apex. This is infracochlear approach to the petrous apex, okay? Yeah. So the jugular bulb, it is here, jugular bulb. Hmm. And part of here, jugular bulbs, part of it goes here, here, part of it says here in the retrofacial approach, and part of it is in the floor of the midlayer, okay? This is all the jugular bulb. Yeah. And that is all the jugular bulb. And ಸಣ್ಣದು ಬರ್ಕೊಡು 1 mm ಬರೋ ಪ್ಲೇಸ್ ನಿಮಗೆ ಇಲ್ಲ ಡೈಮಂಡ್ ಕೊಡ್ತಾರೆ ಡೈಮಂಡ್ ಕಟಿಂಗ್ ಅದಾದ್ರು ಓಕೆ okay and in order to do cochlear implantation so where do we do the cochleostomy yeah you have seen the round window this is the round window niche okay so we go at the junction where the floor as well as anterior canal meet okay anterior wall of the canal meets okay and this is the site of the we are in the basal tunnel and that accomplishes the cochleostomy. Okay, we can introduce cochlear, the electrode of the cochlear implant through this. It goes into the basal tunnel of the cochlea. We can go on if you are interested to study the anatomy of the cochlea also. You can gradually put ಸ್ವಲ್ಪ more little bit happiness of the
ನೋಡೋಣ
ಇದಕ್ಕಿಂತ ದೊಡ್ಡದು ಇದಕ್ಕಿಂತ ದೊಡ್ಡದು ಇದಕ್ಕಿಂತ ದೊಡ್ಡದು ಕೊಡಲ್ಲ ಮತ್ತೆ ಸೇಮ್ ಹೇಳ್ತೀರಿ ನಮ್ಗೆ ಕೊಡ್ತಾರೆ Okay, that is the basal tunnel of the cochlea. Now, I'm opening, this is the basal tunnel of the cochlea, and this is the second tunnel of the cochlea. And just below the cochleariform process, okay, will be the final turn of the cochlea, okay? Okay. Now you can appreciate in the cochlea, okay, the basilar membrane, okay. I will go to the higher magnification. Okay. Hmm. Okay, this is the basilar membrane on which organ of Carti is situated. And what you see here below, this is where we insert the electrode. Okay, this is the segment, sorry, scala tympani, and this is the scala vestibuli. Okay, of the this thing, uh, of the basal turn, and this is the second turn. Okay, yeah. Now you can see basal turn, second turn. And this is, yeah, anteriorly, we see the carotid, okay? So carotid is exposed. You can see how cochlea is immediately adjacent to carotid. That's the internal carotid artery, okay? Anteriorly, that's the internal carotid artery is exposed, and this is the cochlea, okay? And now we will, yeah. Yeah, now you can see the carotid, both cochlea and carotid. You can appreciate, okay, this is the internal carotid artery, okay? And this is the cochlea. Only thin bone is there between cochlea and the internal carotid artery. So when we, see in cases of ossified cochlea, in order to get into the lumen, sometimes we'll have to drill a good length of basal turn of the cochlea. And whenever we do that, we run the risk of injuring the internal carotid artery. So we have to be very careful. Okay, we have to be very, very careful. And now, in order to complete, the facial nerve translocation, okay, so we have to, okay, yeah, in order to accomplish facial nerve translocation, so we have to mobilize the facial canal. We have to drill all this bone, okay, and mobilize it, okay, mobilize it anteriorly. Okay, this is what we do in facial nerve translocation. Okay, now in order to do ಊಟ ಬಂತ ನೋಡು ಊಟ ಬಂತ್ರೇನಪ್ಪ huh? Yeah, little bone, that's all.
Showing for them,
Ah,
two videos that we have not done the year,
yeah, also,
defection.
okay. Yeah, cochlear nerve is here, okay. So I'm just doing the modulus drill out just to show you how the, okay, that's the cochlear now. Yeah, you can see how the cochlear now here, okay, suddenly ends here into the cochlea and it kind of, gives radial branches to go all around. Okay. Okay. And that accomplishes complete all the steps of temporal bone dissection. Okay. Yeah. One ನಿಮಿಷ, we'll connect to you this thing. Yeah. Okay. Huh? Typical turn here, and let me see whether I opened it or not. Yeah, that will be just beneath the bone of the thing. Sorry, cochleariform process. Okay. Yeah, maybe. Yeah, this is the apical turn. Okay. Yeah, basal turn I have drilled. This is the second turn actually. Basal turn I have drilled away. Okay. Yeah. I went in little hurry, so we missed it. Yeah. When you do your dissection, do meticulously. Huh? Yeah. Okay. So that you appreciate all those structures. Huh? Okay. Very good. Very good. Very good. He's doing lecture. Right? ಹೌದಾ?
It's not.
ಅಲ್ಲ, ಅವರ ಇದಕ್ಕೆ ಕನೆಕ್ಟ್ ಮಾಡ್ಬೋದಲ್ಲ, ಇತ್ತು ನೋಡು ನಿನ್ನ ಕ್ಯಾಮ್ರಾದಿಂದ. ಈ ಕ್ಯಾಮ್ರಾದಿಂದ ತೆಗೆದ್ಬಿಟ್ಟು ಇಲ್ಲ ಇದು ಆ, ಇದಕ್ಕೆ ಈಗ ಮೈಕ್ರೋಸ್ಕೋಪ್ ಮುಗೀತಲ್ಲ, ಮೈಕ್ರೋಸ್ಕೋಪ್ ಇನ್ಪುಟ್ ತೆಗೆದು ಇದರಿಂದ ಇದಕ್ಕೆ ಕೊಡ್ಬೇಕು. ಕೇಬಲ್ ಇದೆ ಇನ್ನೊಂದು HDMI ಕೇಬಲ್,
ಮೈಕ್ರೋಸ್ಕೋಪ್ ಇಂದ ತೆಗೆದ್ಬಿಟ್ಟು ಕೊಡ್ಬೇಕಾಗತ್ತೆ ಸರ್, ಕನೆಕ್ಟ್ ಮಾಡಿ.
ಇನ್ನೊಂದು ಮೈಕ್ರೋ ಅವಾಗ ಹಾಕಿದ್ದೆಲ್ಲ ಅದು
ಅದೊಂದು ಸುತ್ತಿಟ್ಟಿದ್ದೀನಿ.
ಮೈಕ್ರೋಸ್ಕೋಪ್ ತೆಗೆಗೆ ಹೋಗ್ತೀಯಾ? ಇದು ಮೈಕ್ರೋಸ್ಕೋಪ್ ಇದು. ಓಹೋ, ಸರಿ, ಇದನ್ನೇ ಕೊಡು, ಪರವಾಗಿಲ್ಲ, ಇದು ಒಳ್ಳೇದೇ ಅಲ್ಲ. ಇದಿದೆಯಾ, ಇದು HDMI ಪೋರ್ಟ್ ಇದೆಯಾ ಅದರಲ್ಲಿ? ಇದೆಯಾ? ಇದೆ, ಹಾಕು. ಆ ಮೈಕ್ರೋಸ್ಕೋಪ್ ತೆಗೆದು ಇದು ಅದನ್ನ ಹಾಕಷ್ಟೇ. ಓಕೆ. ಮೈಕ್ರೋಸ್ಕೋಪ್ದು ಅವ್ರದ್ದು ಹಾಕವ್ರಿಗೆ. ಹಾ, ಅದ್ ಮುಗೀತದು. ಹಾ, ತೆಗೆದು ಒಬ್ರು ಕೆಳಗೆ ಹೋಗ್ರಿ ರೆಡಿ ಮಾಡಕ್ಕೆ. ಬಂತಾ? ಎಲ್ಲಿದಾರಂತೆ? ಇದು
ಹೌದಾ?
ಅಲ್ಲ, ಇದ್ರದ್ದು ಮೈಕ್ರೋಸ್ಕೋಪ್ ಇಂದ ಇಲ್ಲಿ ಕೊಟ್ಟಿದ್ಯಾ?
ಮೈಕ್ರೋಸ್ಕೋಪ್ ಇಂದ ಇವಾಗ ಇದನ್ನ ಇಲ್ಲಿ ಕೊಟ್ಟಿದ್ದೀನಿ ಸರ್, ಇದು HDP ನ
ಇಲ್ಲೆಷ್ಟು ಕೊಟ್ಟಿದ್ಯಾ? ಇಲ್ಲೆಷ್ಟು ಕೊಟ್ಟಿದ್ಯಾ?
2 ಕೊಟ್ಟಿದ್ದೀನಿ ಸರ್.
2 ಬರ್ಬೇಕಲ್ಲ. ಇದರಲ್ಲಿ ಎಕ್ಸ್ಟೆನ್ಷನ್ ಇದಕ್ಕೋಬೇಕು, ಸೆಟ್ಟಿಂಗ್ಸ್.
ಆ ತರ ಬಂದ್ರೆ ಬಂದಂಗೆನೆ.
ಹಂಗಾರೆ ಅಲ್ಲೇನೋ
ಇದು ಕ್ಯಾಮರಾ ಬಂದ್ಬಿಡಲ್ಲ ಸರ್, HDMI ತೆಗೆದ್ಬಿಟ್ಟು.
ಕ್ಯಾಮ್ರಾ ಕೊಟ್ಬಿಡ, ಅದು ತೆಗೆದ್ಬಿಡು. ನಾನು ಅವ್ರದ್ದು ತೆಗಿತೀವಿ ಅಂತ ಹೇಳಿ
ಕ್ಯಾಮರಾ ಕೊಟ್ಟು
ನಮ್ಗೆ ಕ್ಯಾಮ್ರಾ ತೆಗಿಬೇಕಲ್ಲಿ.
ಅರ್ಥಾಗಿದೆ ಸರ್.
ಇದಾಗ್ತದೆ ಕೇಬಲ್ ಫಾಲ್ಟ್ ಇರಬೇಕು. ಬಂತ? ಹಾ ಬಂತು. ಓಕೆ. Lunch is on the way. You can finish any lecture if you want to do.
Okay, this carotid below. Yeah, okay.
ಯಾವುದು ಬಂತ? ಹಾ
The carotid below, what you wanted to show, you can see very clearly. See the tubular bulb is open here and it is followed to the middle ear. This is the, can you see this? Huh? You have pointer?
ಪಾಯಿಂಟರ್ ಓಕೆ
The
ಇರ್ಲಿ ಬಿಡಿ. ಊಟ ಬರ್ತಾ ಇದೆ ಅಂತ? ಊಟ ಬರ್ತಾ ಇದೆ? ಸಾಕು.
And you know, so that is a dissection that you have to do. Complete carotid below and tubular bulb here and tubular below. See. So this
Yeah.
bone, one of the candidates has done dissection in our place and they have left the bone. So I took this bone one day, Sunday morning, and I went and dissected
ಇದು ಎಂಟ್ರ
till 1 o'clock. Finish the bone.
ಟ್ರಾನ್ಸ್ಫರ್
So idea is not to waste the bone because we don't get the bone.
ಇದೆಲ್ಲ ಟ್ರಾನ್ಸ್ಪೋರ್ಟರ್ ಟ್ರಾನ್ಸ್ಫರ್ ಮಾಡಿಸ್ತಾರೆ.
Transfer.
Now you see the tubular how we have to do it. Invest your money is buying good birth and keep birth for temporal bone dissection also. So that will pay you later, it's not now. Don't have only 4 births and then start doing dissection.
So.
You know, I have almost 80 or 70 births for the dissection. I got 44 now today.
The same birth which you use for surgery, we use for the temporal bone dissection, sir.
This is the, I have opened the tubular bone now. See?
ಒಂದು ಕೇಬಲ್ ಸ್ವಿಚ್ ಮೇಲೆ ಐತಲ್ಲ.
See, if you don't have good births, how do you open to all the things? See, I can't do anything without instrument. You see the tubular how it is going, and I have opened the part of it to show you. It is all in a temporal bone that we got from a forensic department, and they remove the bone and change the tubular column. This is the tubular column becoming a sigmoid sinus. Okay? That is tubular column. So before the we go for structure, I just want to have a small presentation of the listening techniques.
Yeah, finish that.
Yeah.
Okay, these are available in dentalpath.com. You can search there or pinkblue.com. Dentalcard.com and pinkblue.com are the sites to buy handpieces. Handpieces you will get for 1500 rupees each, and you can use them. And when it becomes this one, you can throw it out. 1500 to 4000, you can get handpiece, straight handpiece. Then you can get this is the micromotor in those websites. The next level is Metatronic or any high speed drill. RPM is 80,000. So to have that, you must have IPC. Then if you have IPC, then now there are three types of drills are available with the Metatronic. Number one is a Visao, number two is Indigo, number three latest is a MR use for ENT use. But they are very, very good drill systems, but for the cost. And the weight of the Visao drill is less than 200 grams. It's like a feather in your hand, but the cost is too much. So then in between conventional and electronic, the next best bar is you can trust is a Osho Dio that we have used today. So this Osho Dio binary will be 40,000 RPM is there. You can control the with the foot pedal. You can control this is speed of the bar can be controlled, and this is a pump. So the advantage of this pump is you need not have an intelligent irrigation minister for you. You can keep a tubing that will be supplied to the handpiece so that it will control the saline. You can control the flow of saline, speed of the saline with the foot pedal alone. That's the advantage. The next level of Osho Dock is this is the Osho Dio. This is the latest after this. So this Osho Dio, Osho Dock was there for many years, and then now they moved to Osho Dio, and that is a high end one, that is 80,000 RPM. So this is a time tested machine. So this is a lifetime investment. If you buy this drill system, you'll be more comfortable in your life. So next is the skeeter drill. This is a small, you can get in veneer also, you can get electronic, you can get, this is for tracheostomy and stepidotomy. You can do this called a skeeter burr. So this is a, again, Metatronic one, where you can use a curved burrs for the footplate work. See now, what is the difference between this handpiece and that handpiece is, this is a little contractile is there.
Sure.
And the upper lower one is
Right side.
there is it.
Right side, sir. This.
Wow.
It won't light on screen, that LED screen.
Oh, now I can show. See, this is the contractile handpiece, and see this port is for the tubing and saline. This one, okay. So once after you use the handpiece, you should not allow water to enter into the handpiece or the micromotor. It will go spoil. Then you have to spray the oil and then you have to keep it for the lubrication. So now that's about the oil. This is the oil available. You can use this. So now the most important thing is the burrs. So the burrs are classified into according to composition. They are classified as steel, tungsten carbide. Then according to purpose, it is classified as cutting burr, diamond burr, and polishing burr. According to the length, short burr, long burr, and medium burr. So these are the variety of burrs that you can get in the market. Okay, but for our otological purpose, we are using only round burrs. But many people are using conical burrs, cylindrical burrs, or long cylindrical burrs, but they are not meant for, because they are meant to cut the metal, not the bore. So if you use this burr, you should be very cautious that it may create a complication during surgery. You see this, so many burrs are there. See this round burr, what I was telling you, this point here has got crisscross
teeth. So these birds will not jump actually. They are very safe. They remove the bone very smoothly, but the cutting is not very aggressive. Okay, this one. And these are the various birds. So the cutting burrs has see flutes. The cutting surface of the burr is called as a flute. If you have more flutes, it cuts very less. If you have less flutes, it will cut very fast, but it will jump. You have to understand. So the ideally you should have 8 flute, but is good. 4 flute is very dangerous to use the beginner. 8 flutes are best. And second one, spiral one is even more safer. Okay. So other two, the cylindrical burrs are actually for the dental use, but you can use in the surgery if you are experienced. Okay. So these are the cutting burrs, they are available in various brands, they are available and sizes they are available. But what is very important is you must understand this basic thing. So there are steel and carbide burrs. The steel burrs are cheaper, number one, but they cut very fast and they rust also very fast. Whereas carbide burrs are expensive, not very aggressive like steel burr, it lasts longer. It won't get rusted. Okay, carbide burrs are, suppose if you are using for single hand, means you use only once and then throw it out. The steel burrs are best. So in our country we reuse because one Megatronic burr will cost you somewhere around 3 to 4,000 rupees and you can't afford to throw it. But whereas in the Western world, they are using only once and they are throwing. So that's what I told you. If you have any good friends of you who can help you, not friends won't help many people. But they said, no, it's very difficult to get help. Just in one word. But in England, it's very easy because they don't, the only one use they use and then you can get them if you want. Blades, sinus blades, and the instruments, all that they can get. So this is if you compare cutting and polishing burr, diamond burr, so these are the difference. The diamond burrs are used near the important structures and to control, suppose if there is a bleeding from the bone, you will just drill that area with the diamond burr without saline, it will get bleeding will be stopped because the diamond burr will push the bone into the bleeding vessel. So that's the advantage. So diamond burrs are used near the important vital structures. See, these are the parts of the burr. The size of the burr is dictated by the head and the length of the burr is different from the size of the burr. If I say 6 millimeters, it is the head. If I say 50 millimeters, it is the length. Okay? The head determines the size of the burr. And now, what is very important is this third point. What is this shank is the thickness of the burr. All our hand pieces will accept burr shank thickness of 2.1 to 2.35 millimeters thickness only, not beyond that. If there is a more thicker, our hand piece will not accept. So this is that's what I told about the cutting burrs. And these are the various burrs you can see on that side. Dental people, you can get them. And the burr size starts from 0.6 to 7 millimeters in otology. So whenever you do any surgery, you must have a set of burrs, not a bunch of burrs. Set means, if I say I have a set of burrs, that means I have 0.6 to 7, where 0.6 and 0.8 are used for osteoplasty, where you can make the patient, and whenever you shape the But so all these things, the most used sizes are 5, 6, and 4 are the ones used for the, and 7 is used for making the very big MRI cavity saucerization. And the same thing holds good for the diamond also. In diamond, we have normal diamond and then we have coarse diamond. So this is all the variety of shapes that you can get in a dental depot. They'll sell it for about 800 to 1000, 1200 rupees each burr. Now, there are a lot of physics behind these burrs, which we did not know as a surgeon, but if you know, it's good. See, this is a rake angle, clearance angle, so many angles are there, but you need not know all that. Okay? And you can see a notch here in the burr. So this notch implies that these burrs are meant for high speed locking systems. Okay, electronic burr, we have a lot like that. It will go and sit in that collet. Otherwise, a normal burrs cannot be used for the in the high speed. So now you see this fine diamond, you can see regular diamond, you can see, and you can see coarse diamond. See, this coarse diamond is very good to make the saucerization, to remove the bone. They're excellent, but they don't last longer because they're expensive and you need to replace them very often. Again, so now I want to tell you that this website, you can note down all of you, e-document.com is the US based company where each bulb will be costing around $32. $32 is not much. Maybe 2,500 or maybe 4,000, something like that. But that will come minimum for 200 cases, one bar. So you can buy them in the deals they have sometimes. Any of your friend can buy in US and get for you. If they can carry in their luggage, nobody will question them. In the customs also, nothing to worry. You can buy with them. So they are very good bars I used in the initial part of my practice. And again, these burrs are, you can use it for polishing. All this you can get in the dental people. And diamond burrs are used. And then there are something called curved burrs, where the burr is curved like this. And the beauty of this is only the tip will be moving. See, this is used for posterior tympanotomy and cochleostomy. These curved burrs are available only in the Medtronic. The advantage is, see, when you are using a normal burr with a contact like this, your whole burr will be moving when you want to make a cochleostomy. And this burr will be touching the facial nerve. And there will be unintentional damage to the facial nerve. So the advantage of curved burr is only the tip will be moving, this tip, that's all. So that is the advantage you can have if you have this Visa burr. So you just use, you see how I use the curved burr in a patient who has a, see, I want to remove this bony overhang. You see this is not at all moving, only the tip is moving. See, I used to remove all this burr and remove the retraction pocket and the stay piece very nicely. So that is the beauty of having a advantage. So now this is what I want to tell you. Even if you have a beautiful, very good, high-end, expensive drill in your hand, but your knowledge. See what is in one of the workshops I remember when I attended as a first second year post MS in Stamberger's workshop, he said, it is not the laser, it is not the degrader, it is not the forceps that is doing the surgery, it is the hand that is holding the instrument, and the mind behind the hand is the one which will tell you, dictate the outcomes of the surgery. It is not. Somebody tell, if I have laser, I have done super. It is not the laser, it is not the debrader, but it is the hand
holding the instrument and the mind behind it. Okay. So suction irrigation advantage is you need not have an assistant to pour saline if you are doing dissection in your own place. You can set up, it will cost around maybe 1.5 lakhs. You can invest and make a temporal bone lab of your own. And that time you need not have anyone to help you. You can have the suction irrigator and use the saline. So now, what are the do's is always use the correct size bar and rest your hands on the patients like this. Don't keep the hands like this in the air. And don't try to make a small hole in the, and I will, when you start dissecting, we'll show you how to exactly hold the suction, how to hold the instrument while doing surgery. So short length burrs are very stable than the long ones. And all these things I told you. So when you do drilling a dural plate, you have to do like this long axis. All these things I explained you while drilling, all these things. Okay. So this is about the drill. Use the side of the burr, don't use the tip, and be careful with the shaft. You think that only the rotating part is the head, but the body also will be rotating. Okay. So all these things I have told you. See now, you see in a live surgery how a drill is used. You see now, see I have checked it. See, I am using the side of the bar. See the same principle. Whatever I have done today in the morning, same thing I am doing. See now, no difference. See, the principles are same. How I do dissection, I do surgery. Okay, it is not different. See, systematic. See the movement of the burr and keep on checking the landmarks. See, thinning the posterior bony canal wall, thinning the dural plate. Only thing is, see the what is the problem here is my assistant is not putting the saline properly. That is why my burr is getting clogged there. That should be avoided. Okay. See how drilling is done. See now, almost we have come to the level of the periantral cells. There are the periantral cells. See, I am checking there. Every time I am checking. See, I have opened the periantral cells. Now you can see the saline movement. The moment I see this, I am safe. Always keep on checking the level of your medial wall of the floor of the antrum and the tympanic annulus. Suppose, see, sometimes you may have Parallel septum. So how to know parallel septum? Whether it is medial or see parallel septum is always lateral to the tympanic annulus. But whereas your antrum is medial to tympanic annulus. You check the level of the tympanic annulus. If something is lateral to tympanic annulus, it is not antrum. That's all. So now I come to the level of the antrum. Now I can see the dome of the canal. Can you see the dome of the lateral canal? So that means I am safe. So this is how you must drill, and the canaloplasty also you must do. Okay. So see, this is what I was telling in the morning. See now, I check the bar is rotating in a anti-clockwise direction like this. There is an option in the control unit. See now, it is rotating like this. Without you checking that, you start drilling, bone will not cut. Then you will curse that you are not doing properly and you will feel bad for yourself. So all that you need to check. Okay. See again, direction of drilling. Anterior to posterior. See, anterior to posterior. See, what you have to observe here is my burr is not at one point. See how it is moving. And you see the burr is how the burr is removing the bone. Never do surgery with a blunt burrs. That will damage your fingers. You may save some money, but ultimately your lumbricals will get damaged for a period of time. Keep on changing the burrs. It's the direction of drilling and direction. This all I told you. Now, this is the one thing that I want to stress. Don't do this. See now, I am doing canalplasty. The entire canal skin has come into my burr. Why this has happened? Because I want to do it fast, finish fast and go somewhere. Don't do that. You take a diamond burr and protect your this one, but still all these things have happened in my initial days. This is about 23 or 25 years back video. You can see single chip camera I had that time and cut covered with the cotton balls and on the drill, all these things I told you. Canalplasty, all these things I told you. Now, this one I want to tell you. See, now while drilling, sometimes you may hit the jugular. While doing for a patient of a cholesterol about 4 or 5 years back, I myself, I was just opened the jugular. See that I opened a part of the jugular here, which has gone unnoticed. And now the small rent has happened. Now you see how it is repaired. So now I just want you to observe. Suppose if you get same picture, how to control the bleeding. See, first don't get panicky. Then put a pressure like that. Pressure. Nothing more than that, pressure. So now you replace that. Just see how it is done. See, now what I am doing, I am replacing the glass piece with a gel foam bigger than the defect, not smaller than that. See? See, the suction is a very good instrument. You can use it in so many ways. Hold this by watch for 5 minutes. Don't just remove it immediately. Then, now I take again a glass piece and press it against the for 5 minutes. This was a cellular mesh side. I did both sides surgery for this one. So it has stopped. So now on the end of surgery, what I did, I completed the surgery and I put it soft tissue and I put a inferior based musculoperiosteal clamp on that so that when we came, it should not damage the area again. So that's what I have done. So this patient is doing well. So all these things I don't want again to repeat. So what I want to tell you is, this is the conclusion that I want to give. Understand the anatomy and you can see this photograph. In 2007, myself, Prahlad, and all of our team went to Italy to learn the temporal bone dissection, and we were 25 people in that course. We were there for 7 days. So we have spent a lot of money in learning. No, we were there for 7 days. You can see this is Dr. Mario Sanna standing, and this is Dr. Apparao, the ISO president earlier. So all this was a team. We went, and so why I am telling this, you have to spend money to learn. There is no shortcut to learn. You have to keep visiting a lot of places and learn. I'm sorry. So these are the bones that we got in the Europe. You see the bones are very bigger than our temporal bones, and there are injected bones. But the courses will somewhere will cost you around maybe 1 lakh to like that, but they're good if you can attend. So you have to attend, spend some money also, so that, so this is the thing that you have to sharpen every time. Each has got its own repeated practices. Remove the piston and keep. Okay. Thank you. And thank you, Prahlad. Then I think this also I want to show. See this video. One of the postgraduate they have wanted to do particle mastery. They directly went inside. You see this? This you should not do. You have to do a wide knee. See this what they have done. They have made a buttonhole into the sigma segment. Now it is difficult to control. So you have to, that is why I was telling, always you have a wider drilling exposure so that you can have a view on what you are doing.
When you know videos to show pattern, you can cut another 5-10 minutes.
Oh, that?
Comes.
Oh, yeah.
You know, another 5-10 minutes.
ಏನು ಆಗ್ತಾ ಇಲ್ಲ ಏನು? ಹಾ. See, Dr. Prahlad was asking, how do you manage the case of cholesteatoma with a fistula? You see this? This is a patient who had a cholesteatoma and he had a pre-op fistula also. See, this is the fistula you can see. And whenever you see a cholesteatoma along with fistula, they will always have decent facial nerve because before it damages the labyrinth, it damages the facial nerve, it exposes. See, now I am dissecting the cholesteatoma matrix from the foot plate, the sharp instrument, you see, and you see very big fistula there. Okay, so what we have to do is we have to plug that fistula with the fibrofatty tissue and cover it with the, and most of the them they will tell, see, if you remove the see, this is the grade 1 fistula. That means this patient has a just exposure of that. You can see this. This is a fistula. Okay, but it is not, endostem is still intact. So this patient had giddiness, but it is not opened one. See, you can see the fistula very clearly. Okay, and you see the facial nerve exposed. Most of the times I see whenever the fistula is there, facial nerve is exposed. See, that is what I have done the repair. Put a compressed periosteum on that. See, facial nerve is exposed. You always use a fibrofatty tissue, and I have heard many people telling that suppose if you remove the disease and open the labyrinth, patient will end up in a dead ear and all. Most of the patients, nobody has a complete SN loss even after removal of so much of the disease. I have done removal one patient. 1 minute. I will show you this patient who had a cholesteatoma going into the fistula, into the semicircular canal. I have drilled the semicircular canal and I have removed the fistula, disease. Patient never had any loss of so much of loss of hearing. I am just searching for that video. So many videos are there about the cholesterol, you can see. I don't know when where they are. Yeah, see this patient had a subcervical fistula. You can see both ends. After removal of the disease, I have just removed all the disease and plugged the I took the fibroperia, then closed the fistula. None of the patients had loss of hearing. Okay. See, this patient had a, you see the video, classical mass behind the tympanic membrane, pulsating. Can you see that? And the patient has pulsatile tinnitus also. So what I did, I see, can you see that pulsations? Yeah. So what I did, yeah. So I started elevating the tympanic membrane like this, and I can see the tumor in the middle here. It is most of the times it is in this patient. You can see it is occupying the entire anterior. You can see this tumor here and inferior part. It is not in the posterior part. You can see the tumor here. I have tried to remove this tumor with the TM flap intact, but it was not possible. It was coming in my way. So I removed this TM flap completely out and kept it in a saline and removed the tumor. Yeah. Then next step is I did a canalplasty because I have to widen the canal to see the tumor as a in toto, because I removed all the skin so that because I don't have any control over the anterior part. So now how I am drilling the anterior canal. Then I started with a bipolar. I started dissecting. See now this bipolar got this TM flap got entangled in the bipolar and it got cauterized. So then I understood that with this in the place I cannot remove the tumor. I removed the see I removed this TM flap. Now I am comfortable. See how I am drilling the anterior canal like this. Okay. Then I cauterized with the bipolar and I am removing the part of because the tumor was going under the malleus. So what I did, I took the malleus nipper, see, and I removed the tip of the malleus so that I get full view of that. Then that is the place where it was arising from the keratotympanic plexus. It arises from the is a tympanic plexus, no? So I removed the tumor and I found one bleeder was there. Just you cook the tumor with the bipolar, that's all. Nothing. See, it was arising from here. Can you see that? This fiber was the origin. And that was the bleeding was there. Then after removal, I replaced the tympanomeatal flap. This is the tympanomeatal flap. Then I put the temporal fascia for the defect that I created because I touched the temporal flap with that. So post-oral route I did. So this is a 70 years old female, and in my practice of 30 years, I have seen only 5 patients or 7 patients globus tympanicum. This is the only patient I operated. Whenever I say surgery, they go away. Yeah.
Can you explain a bit about your IM dissection in a bit slow manner? Because
Which one?
internal acoustic major dissection, that
Yeah.
part of it.
Yeah.
After the exposure of vesting.
Yeah.
Can you repeat that part?
See, one thing is, if you want to, hey, ತೆಗೆದು ಬಿಡಪ್ಪ ಈಗ. Hello, ಇದು wire ತೆಗೀರಿ. See, internal aortic meatus, see, this is the vestibule. Because if I open the vestibule here, directly I will see the nerves. But that is not the case. I want to actually, so this is the vestibule